I would agree with you. It's very difficult to get it paid for, which is one of the problems, I believe, when you start talking about opiate abuse and things, is the cost of some of these less abuse-oriented medications that are out there that are potentially be used. It's very, very difficult as a physician prescribing them to get them through the insurance company because they don't want to pay for many of these things. And you're kind of robbing Peter to pay Paul. You're taking them off another addictive medicine to put them on something else addictive, but what happens is you're less likely to have the big problems that you would have with the other medications of the folks dying, and you're not going to get somebody stealing it. They may steal it once out of your medicine cabinet. When they find they can't get a high, they're not going to steal it again.
They use it sort of as a break when they don't have money to detox. They don't have money for heroin and opiates. They take those spots of food to alcohol. And that's what we see.
Mm-hmm. If I could, depending upon what jurisdiction, I won't put you on the spot as far as the jurisdiction, but I deal with all the major carriers as well as the state insurance funds across the country. And if you get an adjuster who's not approving this, escalate it as quickly as you can right to the medical director's office, and I'll tell you the medical director for every one of the major carriers will work with you to get somebody on this. Because when you put somebody on Suboxone, it's not supposed to be for lifetime. It's supposed to be with an integrated treatment approach to get them within a defined period of time, often up to a year or so, to transition to other alternatives. And with the sublingual, they're not going to get high to transition for that quick hit. That's an easy one, and if you have that problem, let's chat afterwards, and I'll jump in and I'll help you win that one.
Perfect. I wanted to then jump, and like I said, I want to kind of hit a lot of topics so you guys can ask a lot more questions and we can get some things going, to some of the tools that the physicians have out there, so hopefully we can monitor this use of the medication a little bit better, okay? The first one, I'm sure you'd all agree, having an opiate contract would be incredibly valuable. If you're working with physicians and they don't have patients sign opiate contracts, I would suggest maybe you don't work with that physician, okay? Because this is accepted in standard of care in the treatment of patients in pain. That opiate contract should, somewhere in it, talk about single prescriber rule, okay? So this patient gets all of their opiates through one physician. They get it from no one else. I believe they should single out a pharmacy that the patient's going to use so that they're not going to several pharmacies. It certainly makes it easier to monitor, and it holds the patient to something else as well, okay? This physician in an opiate contract, I believe, should have urine drug testing, okay? Now that testing is not screening. These are urine confirmations is what this doctor should be doing, all right? We should be doing positive and negative confirmations. So even if you do a screening test and you get a negative for a certain thing, you want to, a certain compound, you want to be doing positives and negatives to make sure, because as Ken was saying initially, you know, some of these guys are having less positive tests than they are just all negative tests, and we have to be able to quantify that. So the quantification test is it's actually a numerical amount of what is in the person's urine at that time. The other parts, some of the screening things, your doc may say, well, I'm screening the patients and I've got an opiate in that screen and the person was on Percocet or something else. Well, heroin is also an opiate and it comes back positive. So we'll sometimes see folks who have a positive opiate screening test, but then when we take them in and we do an actual panel of different testing for opiates as well as the illicits and the benzodiazepines, suddenly the patient's not just positive for opiates or for their OxyContin or for their Percocet, but they're positive also for their for a heroin test. And as you know, that's where some of the deaths are happening too, because those are folks who are supplementing their pain medication with something else illicit, or with cocaine, or with other medications that, when you put them in combination with the prescribed medications, puts the patient at risk. So not only are you going to do the positives and negatives, not are you not just going to check for the medication the patient's on, but your doctor should be checking for the other medications out there that the patient can abuse. It's for patient safety as much as anything else. And it also helps the physician so that if he does have to discharge a patient, he's got documentation on why he may have to discharge a patient. Yes, ma'am.
And how about the protocol for your nurse?
The,
There's no policy procedure to state your
so,
there's a specific protocol that you observe to you before the cancer.
I don't believe most physicians do that in their offices, okay? I know if you are injured on the work site and you have a forensic test done, they actually do that. They put a blue dye into the toilet and all of that kind of thing. But we do, when you send to the lab should have indicators to see if it looks like urine, okay? So specific gravity, nitrates, what are the other ones off the top of my head? The temperature of it. There's 3 or 4 different things that we'll look at to make sure that it looks like it's valid urine. So the doctor should get a report that says, does this look like valid urine? Now, of course, they can use the Whizzinator. They can use somebody else's pee. I mean, there's all kinds of cool things. If you have to do urine tests, you can find nifty things online that you can put somebody else's urine in that you know is clean, okay? So people can get around this absolutely. There's really, the other problem, not problem, but the other potential problem with urine drug testing is in medicine we haven't been able to sit down and say this is the best way to test patients monthly, every 3 months, every 6 months. I know at Pain Week last year they talked about, well, if somebody's on strong pain medicines, you got to do it at least twice a year. If they're on really strong pain medicines, at least every 3 months. I don't know. We have several physicians that if they're going to treat and manage patients with chronic opiate use, they're testing them every month.
Also, on protocols, a recommendation is don't allow the urine collection to be done at a physician's office. Couple of reasons. You have to have it's same thing like a DOT physical. You have to have chain of custody for the urine. You have to make sure that it's handled properly, it's kept at the right temperature. But what's happening with several of the docs, and it's happened nationally, and a couple of labs have been shut down already. The labs will then charge for each individual drug in a separate screen rather than doing the full panels. So you want them to go to a reputable lab that's going to give you an appropriate test under control situations. If anyone's never been in a drug testing bathroom, as was just mentioned, the toilet water has changed color, the sinks are shut off, it's supposed to have a certain type of door, and somebody's supposed to be able to observe.
I'll respectfully disagree.
Okay.
They don't have to go to a special lab. This is not forensic drug testing. This is not forensic drug testing. This is clinical drug testing. This is helping a physician guide their treatment, making sure their patient is taking what they're supposed to take. They're not supplementing with what they shouldn't be supplementing with. And exactly, people who get opiates already feel like everybody thinks that they're a drug abuser, and if we start sending these people to labs where they have to be subjected to a forensic urinary test, I'm going to have to disagree.
Point taken.
Yeah. Exactly, yeah.
Honestly, I think the biggest issue that we're facing as employees, attorneys, versus what Ken is talking about from the, let me call it the ivory tower. He sees it as an opioid crisis from looking down on it. And we as individual representatives are dealing with individuals who have a pain problem that Dr. Morton has talked about, that Joel's talking about, that want a solution to that problem, that don't want to be addicted, they don't feel that they're addicted to anything, they're willing to go through all sorts of programs, whatever can do to help them, but what these guidelines that are coming out don't approach anything other than in a cookie-cutter manner. And Ken, I have to disagree with you on these guidelines. Massachusetts passed guidelines. We have all of these things on them. And, you know, I'm the one who irritated this poor Mark over here because, you know what? I'm trying cases where the insurer is asking the judge to make a decision as to how many opioids my client should get. And this is wrong. And I don't know what the solution is, and Ken, I don't believe guidelines are the solution to the individual problem.
If I respond.
And Joel has the same problem. He's treating a patient.
I agree with you.
Well, what's the
Let me qualify.
solution?
I agree with you. Guidelines is simply guidelines meant for the masses. And guidelines, and if you read the premise of any of the guidelines in the opening statements, is that each patient must be treated as an individual. And the guidelines is simply a baseline, and each case really needs to be addressed. And the patients you're describing, people should be bending over backwards to get them what they
But
need.
insurers, don't you all agree? Insurers take it the wrong way. They see a guideline and they say, okay, this is it. You can't get more than 120
Morphine
opioid equivalents per day, and if you're on 121, you're a bad, bad, bad human being, and off you go.
If it makes you feel any better, the regulatory community is coming down on the insurance companies, and we're trying to drum that into their heads, that because there's a guideline doesn't mean this is gospel. We've got to treat every patient as an individual.
But once you create guidelines, aren't you then asking a judge to make a decision?
What it's really doing is setting a threshold for a red flag. And should a judge be making a decision? Absolutely, positively not. I want a physician speaking to a physician to understand a case, to make a medical educated decision.
So one of my points was certainly going to be that we need to train physicians better. I will tell you from my training in medical school, which was a long time ago, that we weren't taught much in pain medicine, and the treatment of pain is becoming its own subspecialty. So I believe we're going to get better at this, but it really puts the emphasis, if your clients are seeing somebody and you've got some concerns, maybe you should look and see who does pain the best in my neighborhood and who do I want my patients to see. Yes, in the back.